I have come to the advocacy world because of an adverse event, the needless death through medical error, preventable medical error, of my own 21-year-old son, Kevin. And it certainly became very clear that every point of contact within the Irish healthcare system failed him. And it's important to remember that adverse events, when they do happen, they happen to real people. Kevin was more than a statistic. He was more than a medical condition. He was a young man full of life, a challenging young man. He was handsome, strong, carefree, but more than anything else, he was my beautiful boy. The identified failings and shortcomings certainly related to inappropriate treatment and management, together with issues of communication and data handling. But the important thing and the very sad thing was that because of damage limitation efforts in the aftermath, learning opportunities were frustrated. And if you like, those learning opportunities were forfeited. And that certainly added to the tragedy. And that is one of the reasons that I'm really pleased to be here tonight, because we are seeing here, if you like, a piece of technology which can provide that kind of learning, that way forward. Because if we don't acknowledge error, well then we certainly will not do anything about it. And this particular tool appears to promise to advance patient safety through that very all-important reporting and learning piece. So, as pharmacists, and particularly hospital pharmacists, you do find yourself at a certain remove from the patient, but you are a very important cog in the wheel of healthcare delivery. And you can certainly contribute, if you like, to this fully compliant, robust reporting and learning system. And so, for that very reason, I think that it is really incumbent upon you to do the right thing, to observe existing guidelines, to strive for best practice, to challenge each other in that regard. And I certainly found in the aftermath of Kevin's death, there wasn't any great evidence that when things were going wrong, when he was deteriorating, nobody was challenging either the system or the people who were dealing with him at frontline level. And sharing your learning from errors and incidents, and it's important that you would learn from each other as professionals, that in the aftermath of an adverse event, you would undertake the all-important root cause analysis, and it's important to include patients and families in that as part of your reporting and learning protocol. Records, keeping impeccable records, constantly referring to them, listening to and respecting patients and families, knowing personal limitations. It's a very wise individual who knows his limitations, and replicating what is good and being always vigilant for opportunities for improvement. And again, the key thing, communication with patients and families through practicing dialogue and meaningful collaboration with patients and families. And above all, when things do go wrong, it's about being honest and open, giving that meaning to the tragedy, seizing that very important opportunity, and acknowledging error and allowing the learning to occur. The time immediately following an adverse event has been described by Albert Wu, an international guru in patient safety, as the golden moment. And very often the opportunity is lost because of defensiveness, efforts to being caught up in this no blame, we don't want to blame anybody. And I certainly would say that disclosure is not about blame. It's not about apportioning blame, it's not about accepting blame, it's about integrity, and it's about being truly professional. Defensiveness, insensitivity, lack of compassion can compound the trauma for patient and families, and can sometimes actually be more damaging than the event itself. And I would certainly say that a prerequisite to focusing on any aspect of healthcare, such as medication safety, is that we would embrace and really own the principles of recognising patients as collaborative partners. We can no longer remain passive in relation to our own healthcare, that we would respect patient autonomy and provide care that is truly patient-centred. And care cannot genuinely be described as patient-centred unless it's perceived as such by the patient. That partnership has been identified as a key theme in safety. Patients, health professionals, policymakers, healthcare leaders should certainly be working together to prevent avoidable harm. And in that wide spectrum of error, medication error, you will agree, is eminently avoidable. There are so many opportunities to avoid error in the medication, delivery of medication. And I suppose if we compare yesterday to today, historically patients presented with symptoms and expected the doctor or the pharmacist to recommend a potion that would either alleviate or cure. And there was a certain mystique, if you like, surrounding all of that process, with the doctor or the pharmacist having this esoteric data which the patient wasn't privy to. And the patient, by and large, surrendered himself in blind faith. Well, now in modern times, that scenario is no longer applicable, nor is it acceptable. Healthcare professionals certainly need to collaborate with patients, and they need to help us understand our medication therapy. We need to know our drugs and doses, why we're on each drug, and we need to be aware of any signs or symptoms of adverse effects we need to watch out for, and what we should do should they then occur. The report of the Irish Commission on Quality and Patient Safety and Quality Assurance says that its framework, its patient safety framework, is based on the concept of knowledgeable patients receiving safe and effective care from skilled professionals in appropriate environments and with assessed outcomes. Very succinct, but it does have all the ingredients that are required. Knowledgeable patients are key to safe care, and in that context, we need to strengthen patients' capacities for sound medication self-management. Compliance, together with adherence to instructions to complete the full course of medication prescribed, for example, are greatly influenced by the quality of information imparted to the patient during the consultation, opportunities for prevention of error, and also ensuring optimum use of medication are present at all levels of healthcare. And I can certainly remember, it's quite a while ago now, my own mother, then in her late 70s, was presenting with symptoms of Parkinson's disease. And I was quite upset by this. She was finding it difficult, and I was finding it difficult watching her, displaying the symptoms. So I went and I visited her GP, and I was pleading, if you like, for her to offer some solution, and she said no, that there wasn't anything further she could do. But during the course of the conversation, she did mention that the only Parkinson's she herself had ever seen alleviated was drug-induced. So I returned home, and again we're sitting having a cup of tea, and again my mum her head is bobbing, tongue in and out, and she's cup rattling. And I look at the back of my kitchen door, and what do I see? A foolscap sheet of paper. Now, we don't even have foolscap sheets of paper anymore now, but on that sheet of paper I was keeping track of her wide range of medication. And it suddenly dawned on me, sure, these are all drugs. So I took the piece of paper and returned to the surgery, and I said to her, I picked up on something you said earlier this morning. This is my mum's regime. Is there any possibility that it might apply in her case? So she said, well, the only way we can find that out is to take her off the drugs. And there was no advice regarding weaning her off, and in my ignorance I stopped her immediately. And we did have a week of monkey on my back, she telling me that there was smoke coming out from behind the wallpaper and such things. But within 10 days, all symptoms of Parkinson's disappeared, never to return. So, in fact, it was drug-induced. And it makes me wonder how many other elderly patients are in a similar situation. And I see a very strong case for regularly monitoring and reviewing the medication regime of all patients, but of this older age group in particular. And I know my own local pharmacist, the community pharmacist where I live, has taken it upon herself to do that particular exercise for all of her clients.